It's my great pleasure tonight to introduce the Australian-Japan Joint Neurodegenerative Disease Symposium public lecture. My name is Dr Ashley Smith, and whilst I now work at the University of South Australia, I did actually study at the University of Adelaide. I really enjoy coming back to the University of Adelaide and working with colleagues at the university. So I'll be the MC tonight. But to welcome us and do an acknowledgement of country, I'd like to introduce Professor Andrew Zanatino. He's the Interim Executive Dean of the Faculty of Health Sciences, Health and Medical Sciences at the University of Adelaide.
Thank you, Ashley. Good evening, everyone. As Ashley indicated, my name's Andrew Zanatino. I'm the Interim Executive Dean for the Faculty of Health and Medical Sciences here at the University of Adelaide. And I'd like to welcome you all this evening to what I hope will be a really informative and entertaining evening as well. So, welcome to our beautiful Adelaide Health and Medical Sciences building. We took possession of it a couple of years ago now, and it's been a real treat to live in a new, wonderful and very interactive building, so welcome. Before we begin, I think it's important for us to acknowledge the Kaurna people, the original custodians of the Adelaide Plains, and the land on which the University of Adelaide's campuses at North Terrace, Waite and Roseworthy are built. On behalf of the University, I pay my respects to all Aboriginal and Torres Strait Islanders, past and present, and acknowledge their ongoing custodianship of the land on which we are meeting here today. As you will know, here in South Australia, we're really blessed with some of the finest wines in the world. And what's the secret to making a fine wine? Arguably, it's to letting age well. So the human brain is no different. It also needs to age well. As we'll hear tonight, we live in a rapidly ageing world, and while it's a wonderful thing that we're living longer, we need to make sure that we remain healthier for longer also. So it's something that we call the health span, so that period of time in which we live well. As our speakers will explain this evening, this is particularly relevant for countries like Australia and Japan. In fact, Japan has the longest living people in the world, and Australia is actually the fourth longest living people in the world as well. And according to the World Health Organization, by 2050, what I find amazing is that 1 in every 5 people on this planet will be over the age of 60. It's rather an incredible statistic, I think. This means that we need to take steps now to ensure that our population of older adults continues to grow, that we're in a position to support their healthy ageing. This is particularly important when you consider that so many diseases are associated with ageing. So one of these, and one of the most devastating, is dementia, of which Alzheimer's is the most common cause, accounting for about 75% of all cases of dementia. And what's staggering is that there are 50 million people worldwide who are currently living with dementia, and there are 10 million people diagnosed each and every year. So anyone who has a friend or a loved one who has dementia, you know how devastating it can be, because it actually robs individuals of who they are, and it robs them of their independence and ultimately their life. So it's a devastating disease. And in fact, dementia is actually the second leading cause of death in Australia and the leading cause of death of women in Australia. So it's something that I didn't know about, and when I was informed of it, it really did surprise me how incredibly frequent and how devastating it is to our community. And given that the largest risk factor for dementia is ageing, the number of cases of dementia is only set to rise as our community ages. So we need to take steps now to try and combat this terrible disease. And so in line with this, in May of this year, the World Health Organization released guidelines for the dementia risk reduction. And our speakers tonight will explore dementia in more detail, and they'll discuss what is known about the causes of dementia and how it's currently being treated and what can be done to reduce the risk of developing dementia. Both are experts in the study of neurodegenerative disorders, and particularly in the case of dementia. And our first speaker is Professor Masahisa Katsuno of Nagoya University. I was practicing that all day. I know him as simply Masa. And he received his MD in 1995 and his PhD in Neurology in 2003, both from Nagoya University. And since 2015, he has been a professor and chair of the Department of Neurology in Nagoya University. Our second speaker is our own Dr Lyndsey Collins-Praino, and she's the head of the Cognition, Ageing and Neurodegenerative Disease Laboratory here at the Adelaide Medical School. She received her PhD in Behavioural Neuroscience from the University of Connecticut in 2011 and completed a postdoctoral fellowship in the Cognitive Neuroscience Division of the Neurology Department of Columbia University prior to moving here to the University of Adelaide in 2014. So we hope that you'll leave here tonight with a greater understanding of dementia, as well as the steps that you can take in everyday life to reduce your risk of developing dementia. So it gives me great pleasure to hand over to Ashley Smith, who will now introduce our first speaker. Thank you.
It gives me great pleasure to introduce our first speaker tonight, Professor Masahisa Katsuno. And Professor Katsuno will be talking about cause, therapy and prevention of dementia. So please join me in welcoming Professor Katsuno.
So good evening, ladies and gentlemen. So thank you very much, Dr. Ashley, for your kind introduction. So my name is Masahisa Katsuno, so in short, Masa, from Nagoya, Japan. And it's my great honor to be here to talk about dementia. I and my colleagues over there are from Nagoya. So Nagoya located in the middle of Japan. And our city, Nagoya, has some sister cities all around the world. For example, United States, Los Angeles is our sister city. Mexico City, and in China, Nanjing is our friendship city. And in Europe, Turin, Italy, is our sister city of Nagoya. And we have another very important sister city in Australia, which is Sydney. I'm sorry, it's not Adelaide. But our university, Nagoya University, has a very tight relationship with the University of Adelaide in terms of medical education and also research. And actually, so Lindsay and I has a collaboration on the research on Parkinson's disease. That's the reason why I'm here in front of you today. So I'm going to talk about dementia, but before starting my lecture, I'm going to ask you a riddle. It's a very old riddle made by Sphinx in Egypt. He asked this riddle to the stranger. What walks on 4 legs in the morning, 2 legs in the afternoon, and 3 legs in the evening? Do you know the answer? Yes. Oh, 1/4 knows the answer. This very cheesy question. The answer is human. So 4 legs in the childhood, a baby, and then 2 foot, and in elderly needs the cane, 3 feet. So next riddle is very, very original one. A riddle I created. So no one knows the answer. So please think about it. So it used to be a pyramid, just like a Sphinx, Egypt. But it's going to be a candle. What is this? The answer is population pyramid. So yes, and in 1970, around when I was born in Japan, so Japan has a pyramid of the population structure. But now, it's not a pyramid anymore. Lots of elderly people, but less the children. And in 30 years, it's going to be a candle-like shape. And this kind of change of structure of a population is happening not only in Japan, but also in Australia. So Australia also has a pyramid in 1970s, but now it's not a pyramid anymore. So this is the underlying cause of the rapid increase of dementia in not only in Japan and Australia, but also almost every country in the world. The progress also increase, the speed of increase is much more rapid than ever expected. So this is a worldwide problem in the medicine and also the society. So what is dementia? This is a dementia, the definition of dementia. So dementia is a group of symptoms affecting memory, thinking, and social abilities, severe enough to interfere with daily life. So even in a healthy aging, we have a decline of a memory or cognitive function like this. So our cognition increase in the childhood and reach the top, the maximum at the 20s or 30s, and then it has a slow decline with aging. But in the patient with dementia, cognitive function reaches the top maximum as well, but has a rapid, relatively rapid decline. And this leads to the problems in the daily life. So this is a dementia. So my next question is, what is the difference between dementia and Alzheimer's? Can you answer this question? Or no? Oh, one, two, maybe. This is very common terms and very looks like each other, but it's different. Because there is various causes of dementia. So Alzheimer's dementia is a leading cause of dementia worldwide. It's account for 60 or 70% of the total dementia. But also there is another causes of dementia, such as Lewy body dementia. This is the second popular cause of dementia, and also mixed type and vascular dementia, and so on. So today I'd like to talk about two main dementia: Alzheimer's disease and Lewy body dementia. I'm going to start with Alzheimer's. So Alzheimer's is the most common cause of dementia, which was found by Dr. Alois Alzheimer. It's like 1906 in Germany. So he's a German psychiatrist, and this woman is the first patient he diagnosed with dementia. So there are some very common symptoms and signs of Alzheimer's disease. For example, memory loss. This is core symptoms of Alzheimer's disease. And also patients with Alzheimer's has challenges in planning or solving problems, or difficulty in completing tasks, or confusion with time or place. And also they have trouble understanding visual imaging and spatial relationship. This is the reason why patients with Alzheimer's disease often get lost when they go shopping or go outside. They also have some new problems with words, and misplacing things, and judgment, and work and social activities, and also mood and personality as well. So now we have 4 kinds of therapy. Actually, it's drugs against Alzheimer's disease. So 3 of them, so donepezil and galantamine and rivastigmine, is classified as acetylcholine esterase inhibitors. So these 3 drugs increase the level of acetylcholine in the brain, and it activates a neuronal transmission. And the other drug is named memantine. This is a glutamate antagonist. So by antagonizing glutamate, so memantine prevents the neurons from insult of Alzheimer's disease. So even though we have these drugs for the patients right now, but these drugs cannot stop the progression of Alzheimer's disease, because this drug is just a symptom relief. It's not a preventive drug. So to prevent the Alzheimer's disease or stop the progression of dementia in Alzheimer's disease, we need to understand what's going on in the brain of Alzheimer's. There are three important things which are happening in Alzheimer's brain. First, amyloid beta deposit outside the neurons, as you can see here. This is relatively huge aggregation of protein named amyloid beta. And second thing is tau deposition. Tau is another causative protein of Alzheimer's disease, and tau accumulates inside the neurons. And these two attacks, so amyloid beta and tau, results in the neuron loss in the brain and leads to the memory loss and the dementia. This is a scheme of the time course of amyloid beta and tau deposition. So first, neurons are healthy, no deposition. Then, first amyloid deposit outside the neurons. This is the first step of the Alzheimer's. And then, tau aggregates inside the neurons. So these double insults leads to the neuron damage and the neuron loss, actually neuron death. And then people get dementia. This is the mainstream of the pathogenesis of Alzheimer's disease. And there are ongoing projects to stop the amyloid deposition and also to stop tau deposition. These attempts have been very successful in animal models, but not so in clinical trials. For example, this is a result of translational research from basic to clinical of vaccination for amyloid beta. As you can see in the left-hand side, the vaccination for amyloid beta successfully prevent or stop the accumulation of amyloid beta in the brain of the animal model of Alzheimer's. And it also improves the cognitive function of the animal models. But in clinical trials, this vaccine inhibits the amyloid beta accumulation in the brain of the human patient with Alzheimer's disease. But it didn't stop the progression of dementia. So we have a gap between animals and humans. When does the gap come from? One of the important reasons for the gap is the time course of dementia. This graph shows the change of biomarkers in the Alzheimer's disease over the years from onset of dementia. So as you can see here, this thick red line, this shows the amyloid beta deposition in the brain, which was measured with a PET, positron emission CT imaging. And as you can see here, this is the timing of the onset of dementia, but the amyloid beta start to deposit more than 20 years before the patient notice their memory loss or some other symptoms of the dementia. And so another important thing from this slide is, so amyloid beta has no more deposit after the patient gets dementia. So this clearly show that we need to stop the aggregation or accumulation of amyloid beta before the onset of the dementia, not after the onset of dementia. So that's why now there are ongoing prevention trials of drugs for Alzheimer's disease. So these are main global clinical trial of prevention of Alzheimer's disease. And the biggest one is A4. But all these prevention trials target, it's not patients, but people with normal cognition. So elderly people have normal, or maybe it's a very mild deficit of cognition, but with some risk of amyloid beta deposition or Alzheimer's disease, such like the people with amyloid beta in the PET imaging or gene mutation carriers of hereditary familial Alzheimer's disease. So these clinical trials use antibody against amyloid beta to prevent the Alzheimer's disease in the normal the people with normal cognition. This can be done because now we can see the amyloid beta and the tau in living people using PET imaging, PET imaging. So this slide shows the amyloid beta deposition in the brain and tau deposition in the brain of Alzheimer's disease, the upper two images, and normal cognition people in so bottom two slides to show images. So next, I'm gonna talk about Lewy body disease. So dementia with Lewy bodies. This was found by Dr. Lewy in German, and he was German psychiatrist again too, and he is a disciple of Dr. Alzheimer. He found the disease with dementia with peculiar deposition of a protein, and now it is known as alpha-synuclein. It's deposition seen in this disease. So dementia with Lewy bodies, DLB, has some symptoms. It's very different from Alzheimer's. So patient with DLB has loss of attention and cognitive fluctuation. So sometimes they have very good in cognition, but at times very bad at cognitive function. And also they have visual hallucination. They can see some children or some bugs. It's not real. And also they have REM sleep behavior disorder. I'm going to talk about this later. And also the DLB patient has motor symptoms, which is Parkinsonism, just like symptoms seen in Parkinson's disease. Because both the DLB and the Parkinson's disease is characterized by and caused by the alpha-synuclein deposition. This is the time course of progression of DLB, the dementia with Lewy body. So first, deposition of alpha-synuclein occurs. So this disease has no amyloid beta or no tau, but alpha-synuclein is the main cause of this disease. And then, patient has prodromal symptoms. And then, finally, they develop dementia. So what is prodromal symptoms? Prodromal symptoms contains REM sleep behavior disorder, constipation, and hyposmia, smelling disorder, and so on. Among these, REM sleep behavior disorder, RBD, is the most important prodromal symptoms of DLB. And actually, this is a prodromal symptom for Parkinson's disease as well. RBD, REM sleep behavior disorder, is a violent behaviors during REM sleep. REM sleep is a phase of sleep with dream. We have a dream in the night. But when we see the dream, we cannot move our body because our body has no tensions. We cannot move. even though we see a dream. But the patients with RBD, so REM-3 behavior disorders, they can move their arms and the legs and the total body when they see the dreams. So if they see a nightmare, very bad dream, they yield or do some violent behaviors. So punching in the desk or eating at a wife or husband or something like that. This symptoms is very different, very important because 40 to 90 patients with RBD later develop neurological disorders, including DLB and Parkinson's disease, within 20 years from the onset of these symptoms at night. So our team in Nagoya, now doing a survey of prodromal symptoms of DLB in examinees of annual medical health checkup. So we in Japan, the most employees has to undergo annual medical checkup. So we distribute questionnaires about the prodromal symptoms of DLB in such healthy people. And when we look at the people over 50 years old, some people has autonomic dysfunction, including constipation, and some has RBD, and others have hyposmia. And actually 155 to 5.7% of the people aged over 50 have no symptoms. Healthy people have 2 or more prodromal symptoms. So these people looks very healthy and they don't have any problems in the neurological symptoms, but actually they are prodromal. They may be a prodromal stage of DLB or Parkinson's disease. So we believe that these people is a very important target of the preventive therapy or trial for DLB in the future. So as I told you today, a common feature of dementia is abnormal protein deposit, such as amyloid beta and tau in Alzheimer's disease, and alpha-synuclein in DLB, and TDP-43 in frontotemporal lobar degeneration. And these protein deposit starts 20 or 30 years before the onset of dementia, even in Alzheimer's disease and also in a DLB. So this suggests the needs for prevention or very early therapy for dementia. So this is the main topic of my talk today. So how can we prevent dementia? How can we do that? So one of the important things to prevent, about the prevention of dementia is abnormal protein deposition is a common feature of dementia, but it's not equal of the dementia symptoms. This shows large scale autopsy studies shows the deposition of amyloid beta and tau and the symptoms of cognitive dysfunction. And the data shows that 10% of the autopsied subject has with positive amyloid or tau have almost normal cognition. So it suggests even though the people has the amyloid or tau in the brain, they do not necessarily develop dementia. So this suggests the importance of cognitive reserve. So if there is a very strong house, new strong house, and very old house, and there is an earthquake. So which is strong? Stronger. So stronger house, so new rebuilding, and so this kind of new house is more resistant for disaster. This is the same in the brain about dementia. So there are many known factors which can be a risk or a prevention for dementia. So this study shows the exercise and the risk of dementia. And as you can see here, so moderate exercise has lower risk of developing dementia compared with no exercise. So this suggests that 30 or 40% of the risk can be reduced by moderate strength of exercise. So how to exercise? This kind of exercise is recommended for elderly people. No, never, ever. So WHO, World Health Organization, has a recommendation for the exercise for elderly people. For example, 150 minutes of moderate or intensity aerobic physical activity throughout the week. Or the people with poor mobility, they should perform physical activity to enhance balance and prevent falls. So another point is Mediterranean diet. This has been shown to benefit for preventing dementia. So lots of fruits and vegetables, and a little bit of chicken and fish, and a very few amounts of meat. It's going to be a torture, but this knows to very good for health and prevention of dementia. Sleep has a benefit as well. So this shows the sleep length, the relationship between sleep length and deposition of amyloid beta in PET. And short sleeper has a more abundant amyloid beta compared to long sleeper. Leisure activity is also important. So people has the regular leisure activity has less chance of having dementia. And also, social network is also important. And people has dense social network has less chance of developing dementia as well. So on the other hand, there are lots of risk factors of dementia. So one of the strongest risk factor of dementia or Alzheimer's disease is diabetes. People with diabetes has higher chance of developing dementia compared to people without diabetes. And high cholesterol has also has a risk for future dementia. So this is a summary of risk and protective factors for dementia. Sorry, I had a mistake, but this shows the risk of increased risk. For example, diabetes, hypertension in midlife, and obesity, and dyslipidemia with a high cholesterol level is vascular risks. And this is also the risks for dementia as well. Smoking is a risk too. On the other hand, the rich social engagement, the mentally stimulating activities, or highly a skillful job or something, and also physical activity, so regular exercise, usually moderate strength, and also moderate alcohol intake with Mediterranean diet has been shown to protective for dementia. And the effects of these preventive factors and management of risk factors has been shown in clinical trials. This shows the ongoing clinical trials of multi-domain intervention for preventive dementia. Mainly, this studies was done in Northern European countries, Scandinavian countries, and they target the people with normal cognition or mildly deficient of cognition, and they do the intervention which consists of risk management, which is the management of metabolic and vascular risk factors such as diabetes and cholesterol and hypertension. And also they have intervention of nutrition, the Mediterranean diet, as I told you before, exercise, and cognitive training. And one of the trials shows a very positive results of these multi-domain interventions. In many types of cognitive outcomes, such multi-domain interventions improve the cognitive function of the elderly people in the Scandinavians. So finally, I'd like to talk about, I'm going to do the quiz again. Do you know this person? Yes, you know him. So who is the president before Donald Trump? Can you? Yep. He was very popular, not like this current president, but who is the before Obama? Is he? Okay, who is the before Bush? Oh, great. The husband of Clinton. Who is the before? Wow, great. Papa Bush. But my question is not the Papa Bush. Who is before the Papa Bush? Great. Yeah, it's Japanese people that cannot answer this question. It's very tough for Japanese. Yes, Ronald Reagan. He was passed away more than 15 years ago. And this message is one of his last message for the American people after he was diagnosed with Alzheimer's. He said, "I now begin the journey that will lead me into the sunset of my life. I know that for America, there will always be a bright dawn ahead." So he felt that he's going to the sunset of his life. So this sounds very sad and dark story. But what I want to say at the last of my talk is not about the sad story. So it's not a one-way journey, actually. So between the normal status of cognition and dementia, there is a status called MCI, mild cognitive impairment. Mild cognitive impairment is, just like a literary said, the people have some mild cognitive problems, but they have no problems in the daily life. So they have memory loss, the slight memory loss, but they are okay doing their living, the daily living. But MCI is a kind of a prodromal status of dementia. So once they get MCI, very slight deficit of memory, they will develop dementia. Within 1 year, to 5 to 20% of people with MCI get dementia. But more than 50% people with MCI stay at the same situation, same stage as MCI for 10 years. And more important thing is, someone can go back to the normal. Annually, 10 to 20% return to normal from this in-between status of the normal and the dementia. So they can recover from the mild cognitive impairment. So this suggests a need for prevention or stopping the disease at a very, very early stage of the disease. So this is my final slides and the take-home messages. There are various causes of dementia, not only Alzheimer's, but dementia with Lewy body I introduced today. And in Alzheimer's disease, amyloid beta starts to deposit in brain more than 20 years before the onset of dementia. In dementia with Lewy bodies, DLB, the patients experience prodromal symptoms such as RBD, REM sleep behavior disorder, as early as 15 years before the onset of dementia. So in both cases, there are long prodromal phase of the disease. So that's why there are ongoing preventive trials of dementia. So some of them using pharmacological approach, using drugs, drug against amyloid beta, for example. But some other trials using different methods with multi-domain interventions, nutrition, exercise, and risk management. And finally, management of metabolic and vascular risks, exercise, nutrition, and social engagement just like this is the key for the prevention of dementia. Finally, I'd like to thank my collaborators, and DLB studies was mainly done by my graduate student, Dr. Hattori and Yokoi, and also I have lots of collaborators in Japan, also in Adelaide. Thank you very much.
Thank you very much, Professor Katsuno. I think you can all agree that that was a fantastic presentation of dementia and its risk factors. So I'd like to thank you for that presentation. What we're going to do is, I'm sure you have lots of questions, but I'm going to do a little bit of a cognitive test. I'm going to get you to store those questions just for a little bit longer, because we're going to introduce our next speaker, and then afterwards we'll have a Q&A discussion. I will make one comment on your presentation though. I think had you used the Australian Prime Ministers as a test of the last 6 Prime Ministers, you may have had a little bit more trouble people remembering them, because there's actually been quite a lot of Prime Ministers and a lot of changeover of Prime Ministers. So yes, perhaps that would have been more of a challenge for people in this room. But without further ado, we'll move on to our next speaker tonight. So as introduced earlier tonight by Professor Zanatino, our second speaker tonight is Adelaide University's own Dr Lyndsey Collins-Praino. So she completed her PhD at the University of Connecticut in 2011 and a postdoctoral fellowship in cognitive neuroscience in the Neurology Department of Columbia University. And in 2014, she moved to the University of Adelaide, where she's a senior lecturer within this beautiful Adelaide Medical School. She's been the finalist for a number of awards, both state and national awards, including the 2016 South Australian Young Tall Poppy Award and the 2016 STEM Educator of the Year at the Science Excellence Awards. So tonight Lindsay's going to be talking to us about ageing like a fine wine, how memory and cognitive function change as we get older, and what can we do about it. So thank you, Lindsay.
Thank you to everyone for coming. So we've just heard a little bit about dementia, but I think that what sometimes people don't understand is how is dementia different than the sort of change that we see with healthy aging? So that's a little bit what we'll talk about tonight, a little bit in terms of how our population is aging, what we can expect to see with normal aging, and when we might want to be a bit worried about some unusual changes that we're seeing. So we started the night with this, and as an Adelaide girl now, I have to ask the question, what do these have in common? Very often we think that these two things don't have anything in common, except that one may have some questionable effects on the other, especially up on Hindley Street on a Thursday night. But what else might these two things have in common with each other? Let's see who remembers. Yeah, age. They both need to age well. So we have a beautiful bottle of Penfolds Grange there, and of course you want to age that well. Well, you want to do the same with your brain. You want to age it effectively. You want to make sure that it helps to reach its maximum potential, even as the years pass by. So both need to age well to have their best results. And I've always really loved this quote by Jonathan Swift, which is that every man desires to live long, but no man would be old. Essentially, as long as we've been aging, we've been trying to find ways to prevent it. So here is the mythological fountain of youth. And so people will go and dip themselves in the water, and I'm not sure if you can see in the painting here, but they emerge from the waters young and youthful and revitalized again. Now, we're still searching for the fountain of youth, but I'm afraid the way that search looks has changed a little bit. So you literally can't even go to the grocery store anymore without being bombarded with images for ways to help yourself look younger and more vital for a longer period of time. So that takes the form of all different creams for both men and women. And I have a 2-year-old now. Well, he'll be 2 next month. So I've suddenly discovered that night cream is no longer an optional thing. So there are day creams and night creams and eye creams and all sorts of creams that I never previously knew about. There's also things like injections of botulism toxin into your face in order to try to prevent it from wrinkling. So this raises an interesting question. We're constantly in the search of youth. We're constantly in the search of trying to prevent aging. But what is it about the aging process that we fear so much? What's wrong with embracing our age? Well, certainly our age has changed a lot as human life has evolved. So if you were to be born in the Iron Age, your average life expectancy at birth would have been about 18 years old. Now, we did make gains over time, but you can see that even in 1800, your maximum average life potential would have been about 35 years old, which I'll turn on my next birthday, so I really would have been in some trouble. And even around the turn of the previous century in America, 48 was essentially the best you could hope for. Now, since that time, we've made massive gains, and look at how steep the increase has been since 1900. Now in Australia, in 2012, individuals could expect to have an average life expectancy of 82 years old. Now, this has in large part been driven by advances in medical care. With the advent of things like vaccination, our children are living past their childhood into old age. So that's part of what's driving it. But the other thing that's driving it is that we're getting more effective at being able to treat disease, and hence people are continuing to survive. And so this is a really wonderful thing. Life expectancy is increasing. So here in Australia, in 1950, at the age of 65, men and women could expect to have about 11 years of life longer. But today, that number is actually 17 years of life longer. And it's projected that by the end of the century, it will actually increase to 22 years. So when you blow out the candles on your 65th birthday cake, you know that you have almost 2 decades of life or more still ahead of you. And isn't that a wonderful thing? And this is happening worldwide as well. So when we look at the worldwide picture, Australia is actually doing incredibly well. So Japan has the highest life expectancy for both sexes. It's almost 87 years for females, making it the longest living in the world, and about 80.5 for males, making them 6th in the world. But here, we're in 4th place. And there's nothing too shabby about it. We have a life expectancy of almost 85 years for females. We rank 7th, and almost 81 years for males, ranking 3rd worldwide. So you can see that we're among some of the longest living countries. our world is rapidly aging. So I'm American originally, as you may be able to tell by my accent, so I like to think of it as the boomers are coming, the boomers are coming. As we're having people in the baby boomer generation continuing now to age into older adulthood, we are set for maximal increases. In fact, as you heard Professor Zanatino say before, the number of older people in the world is projected to increase from about 617 million in 2015 to 1.6 billion by the year 2050, meaning that they'll make up nearly a fifth of the world's population. And if you look at the infographic here, it's changing as the years are going on. You can see many countries are getting darker in color. The dark color there represents 30% or more of the population over the age of 60. Now, you may notice that Australia, even at 2050, doesn't turn dark blue, and part of the reason for that is because our fertility rate hasn't taken quite the same dip as some other countries. But regardless of that, as you saw before, we will be heading towards that candle-shaped age distribution. And in 2050, more than 1 in 5 people in the world will be over the age of 60. So, why is that a problem? Don't we want to live longer? Isn't it great that we're increasing our life expectancy? It's absolutely a great thing, and we want to work harder to make sure that we continue to increase our life expectancy. But it's important to remember that just because we're living longer doesn't necessarily mean we're living healthier. Now, the findings have been inconsistent across different studies, but they seem to suggest that individuals at the age of 65 or over today actually aren't any healthier than they were in previous generations. So if you look at the graph here, each of those different colored lines represents a different large cohort study on aging. And what you can see is that when you compare people who were born in 1956 or 1952, who would be part of the baby boomer generation, even 1948 there, you can see that they're really not any healthier than age-matched cohorts who were born in 1916. So this isn't comparing people born in 1956 to people born in 1916 at the current moment. It's comparing them when they were the same age. So what you can see here is that they're actually not getting any better in being able to carry out activities of daily living. Now, there are some issues with this research, and it's almost entirely based on high-income countries. So we don't know what happens when you add in middle and lower-income countries. But one thing that's important to take away from this, and that's a source of real concern, is that in other words, 70 may not be the new 60. And that's a big problem. Not only is it a problem for the people who are actually aging, but it's also a problem when we think about government policies. Because if we have a declining birth rate and an increasingly large proportion of older adults who may not be that healthy when they reach old age, it means that we have fewer people to be able to sort of share the cost of helping to support those older people. We need to address this now before our population really explodes in terms of the proportion of individuals who are older adults. Now, what about Australia? Well, interestingly, actually, just a couple of days ago, I was forced to update this slide because the Australian Burden of Disease study was released. And it suggests, it looked from the difference between 2003 and 2015. So it looked how things had changed here in Australia in that 12-year period. And what they did find is that our life expectancy had increased, which they expected, but they actually looked at what's called health-adjusted life expectancy, which is the number of years that you can expect to have in full health. And what they found was that it did increase for 2 years for men. So they expect about 71 and a half years of full health, and for women, almost 74 and a half full years of full health. And they attribute this, about 89% of it, to improvements in heart health, reduction in certain types of cancer, and also improved infant health, particularly the really precipitous drop in sudden infant death syndrome, or SIDS, that happened with the Back to Sleep campaign in the 90s, when rates really plummeted. So it's great that there are much sort of increased life expectancy, increased health, but again, this isn't consistent across all studies, and I think we need more data to truly understand what's really happening. But it does certainly beg the question, is age just a number? Are we sort of heading into the sunset of our life, as Ronald Reagan said, or can we maintain our health and vitality and enjoyment as we continue to get older? Now, you may know some of the individuals here, so Betty White, bit of a personal hero of mine here. She's an American comedian and brilliant. And this gentleman, you may not be able to tell, but that's Jack Nicholson skydiving there. So definitely examples of older adults who have certainly maintained their vitality into their later years. But we do know that for the average person, multiple body functions will change with age. So we know that there are declines in movement as muscles and bone mass begin to be lost and joints become more fragile and more rigid. We know that loss of near vision will change as it becomes harder for the lens to accommodate up-close objects. So I see a number of neuroanatomy students in the audience, so they should hopefully be able to tell you by next Tuesday when the exam is why that happens. But we definitely see older people will sort of start to move things closer and closer as they're reading because their lens is no longer able to accommodate to help adjust for the object as it moves closer. There's also things like the increased risk for cataracts and also a condition called macular degeneration, which is loss of a particular region of the retina, which leads to blindness. Loss of high-frequency hearing. So high frequency is particularly vulnerable to age-related change, and that's why many individuals will use a hearing aid as they get older. I had this really brought home to me the last time I was visiting the States, actually, and my sister was showing an app on the iPhone that would play different frequency tones, and you had to be able to tell them apart. And there were a few of them that were really sort of high frequency, and my grandfather wasn't able to hear them, but my sister and I were sort of laughing and saying, "Oh, how can you not hear it? It's so high frequency." And then my sister played a tone and I said, "Oh, what happened to your app?" And she said, "What are you talking about? You didn't hear that?" And I went, "Oh my God, I didn't." So even very early on, I was probably about 30 at the time, even early on you can start to have some of that loss of high frequency hearing. You also see declines in immune function, so it becomes more difficult to fight new infections. But conversely, there's also higher levels in the serum of inflammatory cytokines. So it seems like you're getting all the negative effects of the immune system with a little bit of loss of a positive function to fight new infections. The skin starts to get quite thin, and hair begins to go gray and thin. And of course, one of the things that most older adults worry about most is that cognitive function begins to decline. And these declines summed up lead to reduced capacity. So when we look at capacity score across the lifetime, you can see that across many different countries represented in the different colors there, we do see a gradual decline as age increases. But one thing which I find particularly interesting is that particularly when we get to the older adults, look at how much variability there is. So some people age into their 80s and 90s and maintain really high capacity, which is equal to someone in sort of their mid-20s or 30s, versus other people get to the same age and are performing much lower. So I'm really interested in why that might happen and what we can do to try to help change it. Now, we do know that one factor that leads to the most decline in day-to-day life is cognitive function change. We know that cognitive change is a normal part of aging, but it's not just a homogeneous decline. Different types of cognitive function show different risk. So we know that skills like reading and vocabulary actually are pretty resistant to aging, and in fact may become better with age. And it makes sense. The longer you've lived, the more vocabulary you've been exposed to, the more reading you've done, and so therefore your vocabulary continues to maintain. Also, your long-term factual memory. So if we did ask the Australians in the audience to recall the last 6 prime ministers, well, that wouldn't be too long-term memory, would it? You'd be able to use some recent data for that. But when you look at long-term memory, that's another skill that tends to be fairly resistant, although not completely resistant to change. However, other things like visual spatial skills, so your ability to sort of remember where you've parked your car and successfully navigate to it, or motor speed, or what we call executive function, do show quite a bit of decline with age. So when we go ahead and look at that graphically, you can see that if you look at things like speed of processing or working memory, which are represented in the green and the gray colors, you can see that as age increases, you do get a decline, versus world knowledge, represented in the warm colors of orange and red, actually maintain throughout the lifespan and in fact get a bit better with time. But we do know that across many different types of memory, many different types of cognitive function, one of the most common complaints we have is actually decline in memory. And memory isn't just one thing. We can break it down into multiple different subtypes. And in the interest of time, I'll just give you a brief overview of what they are. So one type of memory is called working memory. And this works a lot like the central processing unit of your computer. This is the information that you're maintaining actively at a given moment in time. And for any of you who've tried to remember a phone number when you've picked it up off your voicemail and haven't had anything to write it down, you probably know that it's got a pretty brief capacity and duration. If you're not constantly repeating those numbers over and over, they are gone. We know that the best way to get information into working memory and to keep it there is through that rehearsal. So let's go ahead and check all of your working memory. So I'm going to say some numbers, and I want the audience to repeat them after me. 7, 5. 3, 9, 2. 1, 4, 6, 7. Okay, good. You're all a bit too good at this. Let's make it a little trickier. 3, 9, 1, 2, 6, 5, 4, 9, 0. Whoa. Okay, so most of you were able to remember the first few digits, and a lot of you were able to remember the last few digits, which are what we call the primacy and recency effects. But you noticed that you lost most of those numbers because you were still trying to hear the new number as you were trying to remember the old numbers. You had a lot of interference there. But it really indicates working memory, which is that you can only hold more or less 7 plus or minus 2 pieces of information in your mind at a time. And there's all sorts of tricks we can teach people. We can teach them how to chunk information. We can teach them how to add more meaning to information to help remember it. But in general, it's 7 plus or minus 2. And we do know that while that's the average across all ages, as individuals get older, so around the age of 60 or more, we do start to see a sharp decline in this skill. And actually, declines in working memory are what are hypothesized to drive a lot of the difference we see between older people and younger people on cognitive tests. So you can see here, the green line represents older adults and the blue line younger adults. And as memory load increases, older people, again represented by the green line there, they start to slow down their responses and also lose their accuracy. So younger and older adults tend to be equally fast and equally accurate when there's not a lot to remember, but as you start to add more stress to that, that's when you start to really see differences between younger and older adults. And this is really just a piece of the story because the other major component to our memory is long-term memory, which if working memory is like the CPU, long-term memory is more like the hard drive. This is where you're storing all of the information. And it has an enormous, essentially limitless capacity. So what we have to do is we have to store the memory in our long-term memory. Then we have to be able to retrieve it or load it back into working memory in order to actually be able to work and remember that information again. Now, there are multiple different subtypes of long-term memory, but one of the ones we talk a lot about is episodic memory, which I like to think about like the episodes of the TV show of your life. So, when was your first kiss? What was your high school graduation like? What was it like when you had the birth of your first child? So all of those sorts of memories for the episodes of the TV show of your life. And this is the last type of memory we have that actually develops. And some of you may realize that your parents will tell stories about you doing things like counting or matching colors long before you ever be able to remember having those skills. So if I asked you what your earliest memory was, many of you would probably say around 3, some of you perhaps a bit earlier, particularly if it was a memory that had a lot of significance or emotion attached to it. But yeah, usually it's not for a little bit that we start to develop our long-term memory. And this is the type that by far is the most affected by normal aging. And we definitely see this to a more extreme case in conditions like dementia or Alzheimer's disease. So we like to say that this illustrates the principle of last in, first out. That the last type of memory that you develop is actually the first one that you lose. So you can see here in this study from the Seattle Longitudinal Aging Study that as age increases, you do get a decline in delayed recall, which is the ability to remember after a period of time has passed. And if you're remembering autobiographical information, this shows particular declines. So I won't talk too much about dementia because Professor Katsuno has already done so brilliantly. But it is different. And the normal cognitive change that I've been talking about is far more mild than what we see in dementia like Alzheimer's disease, where we see decline in 2 or more domains, like memory, orientation, language, and decision-making. Now, which domains decline and the extent to which they show decline will differ depending on the type of dementia that it is. So in conditions like Alzheimer's disease, you'll see much more significant impact on memory and on language skills, versus if you think about a condition like Parkinson's disease dementia, changes will be more to things like attention, decision-making, and visual spatial skills. We do know that dementia, as we heard earlier, is affecting 50 million people worldwide, and there's 10 million new cases each year. And what's really scary to me is that the number of cases will actually double every 20 years, particularly as the baby boomer generation starts to age. And there is an enormous human burden of dementia. So if you look at the number of deaths due to dementia globally, you can actually see that Australia is at the higher end of the spectrum, with some of the most deaths due to dementia in the world. Other countries similarly affected are many of the countries of Western Europe and also the United States and Canada. This is thought to be at least in part due to dietary factors and cardiovascular risk that's associated with that. Now, here in Australia, there's actually more than 320,000 Australians currently living with dementia, and you can see that South Australia, sadly, this is a category where we punch above our weight. So when you consider that we have a much smaller population than many of the eastern states, we have a very high number of cases of dementia, in large part because we have a very older population compared to some of the other states. But when we put numbers on this, 3 in 10 Australians over the age of 85 and 1 in 10 over the age of 65 suffer from dementia, and there's 1 new case diagnosed every 6 minutes. That means that in just the time you sit in this room tonight listening to us, there'll be 15 new Australians that are living with dementia that weren't before you walked in here. It's the second leading cause of death in dementia, death in Australia, and the leading cause of death for females. So actually a couple of years ago, it surpassed cardiovascular events for females. And what's really scary is where we're headed, because if we don't have a medical breakthrough, the number of people globally living with dementia will surpass 130 million by the year 2050. And why should that worry? And you should really read that as terrify us. The reason for that is because the total estimated worldwide cost of dementia were $604 billion US in 2010. In fact, if dementia were a country, it would be the world's 18th largest economy, which is really just terrifying. When you look at the cost of dementia next to revenues for companies like Walmart and ExxonMobil, which are just giants in terms of the revenue that they bring in, you can see that it almost doubles it, particularly when you look at ExxonMobil. And this is where it's not so bad, because by 2030, expenditure in dementia is set to reach $2 trillion US. So if you think that this is a bleak picture now, we're just a few years from it getting so much worse. And so part of this is about Alzheimer's disease, 75% of the cases of dementia. We don't really know what causes them, although there have been a lot of hypotheses put forward. We know that one of the predominant risk factors is age. However, 95% of cases are sporadic, meaning that they don't have a clear genetic mutation associated with them. Only about 5% of cases are what we call familial, where you see familial patterns of inheritance from generation to generation because of a particular mutation being passed along those generations. And you can see here that compared to the normal healthy brain on the left, this is a healthy older adult's brain on the left, compared to severe Alzheimer's disease, you don't have to be a neuropathologist to see that there's really severe depletion here. So a lot of shrinking of the cortex, a lot of loss, particularly of gray matter. And this corresponds to a real quieting of the brain. So on the left-hand side, you can see a PET scan of the healthy brain, and you can see a lot of warm colors, reds and oranges. That corresponds to a very active, healthy brain. But on the right-hand side, you can see many more cooler colors, blues and greens. This is the brain of someone with Alzheimer's disease. And you can perhaps see here that the only areas where you still have activity are in the brainstem and the occipital lobe. So really, this is a brain that's gone quiet. A lot of the function that we rely on for cognitive function, for language, for the other activities that we do day to day, they're not happening anymore because there's simply no more function in those brain areas because of the severe tissue loss. And so this is just a slide showing that large increase with age, about a 15-fold prevalence between the ages of 60 and 85. We rarely see individuals become symptomatic before age 50, although there are cases where they do, particularly in familial Alzheimer's. You sometimes will have an earlier onset. But there are other risk factors for AD as well, things like genetics, cerebrovascular disease. We heard a little bit about the vascular risk factors before, smoking, obesity, hypertension or high blood pressure, and one that we didn't actually hear about, but traumatic brain injury. So we know that even concussion, even a single concussion early in your life can significantly increase your risk for dementia, about 6 times the risk. So very significant elevation, and that's one of the things my lab looks at. And as we mentioned before, Alzheimer's isn't the whole story. So there's many other types of dementia as well. So I feel like I've been telling you really horrible things. So is there anything we can do to maintain brain health? I've told you our population's aging, dementia's going to increase, expenditure's going to increase. So where's the good news? We don't want to send you away feeling like, oh gosh, well, here I go on my long march to sunset. The good news is that there is a lot that you can do now. So just this May, the World Health Organization released guidelines for dementia risk reduction. So they looked across the scientific literature and they identified 12 potential risk factors that individuals can target in their everyday life or with the assistance of their medical team. And I'll just point out 3 of them today, things like low levels of physical activity, poor diet, and cognitive reserve, all of which we heard about a bit before. Hopefully the 2 in the middle there, smoking and alcohol misuse, you're in a medical school, so hopefully we don't have to tell you that those things are bad for you. And a lot of the others we've heard referred to before as well. Sorry, and just one thing that I wanted to point out before I move on from this slide is just this little graphic at the bottom here. If we have risk reduction by 2056, we can save over 120 billion Australian dollars. So of course we don't want to reduce dementia risk to save money. We want to help the people who are affected. We want to make sure that they're not converting to dementia. But it's not a bad bonus to have along with it. And so we liked this picture so much, we thought we'd show it to you twice. So adults over the age of 65, I just want to repeat again, at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity, which is more running, more cardio, your heart rate getting up throughout the week. You have to do at least 10 minutes at a time. And if there's any concern over balance and falls, you need to have at least 3 days per week of balance training. My mother has now turned to yoga, which it is almost worth going back to the United States just to watch my mother do yoga. But balance training is certainly something that she has embraced, and I've seen it make a really big difference for her. Muscle strengthening, also 2 days per week. And even if you can't meet these guidelines, do something. Something is better than nothing. We know that it improves cognition, so older adults in a 12-week physical training program showed improvements in both their immediate recall, what they could remember right away, and also their delayed recall, what they could remember after a period of time had passed. And they also showed more blood flow in a region of the brain called the hippocampus, which we know is really important for working memory, which we talked about before. And when we look at the dementia side, so there have now been a number of studies, and just sort of talk about them briefly here. One is the Honolulu Asia Aging Study, which is a very large longitudinal study of aging. And they found that men who walked less than a mile a day had double the risk for developing dementia compared to men who walked 2 or more miles per day. And we would expect that that would be similar in females as well. So while it's great that we now have the tram, maybe we should sort of ignore it and keep walking. And also, when we look at lower cardiovascular fitness and cognitive health in or young adulthood, we know that it's associated with more than a 7 times increased risk of onset dementia early. So lots and lots of studies suggesting now that there is a big association between not being physically active and risk of dementia development. And what I really like is this study by Barnes and Yafe, which I have some graphics here from, which the one that you want to pay attention to is the one in the box here, the red box, which suggests that if we could increase the portion of the population that are physically active by just 25%, we could prevent as many as 1 million cases of Alzheimer's disease worldwide every year, which is just staggering. The idea that we could get that sort of 10% reduction in cases per year with just sort of a little bit of physical activity is really amazing to me. Now, I always get asked, well, but why? Why is exercise important? What's it actually doing for the brain? Well, the truth is that we don't 100% know yet. Many different studies have suggested many different mechanisms. These include things like increasing cerebral blood flow to brain areas that we know are key for cognitive activity, angiogenesis, which is the creation of new blood vessels in the brain that help to increase blood flow to those key regions, neuroprotection, being able to do things like take advantage of your body's natural antioxidant system to help to keep your brain cells healthy, neurogenesis. So for a long time, the sort of dogma of neuroscience was that you were born with all of the brain cells that you would ever have in your life. We know that neurons are what we call post-mitotic, meaning that they don't divide anymore like the cells of your body do. So this was what I certainly learned when I was an undergrad in school. But then not too long ago, there was this major sort of revolution in the field, which is that there are a couple of brain regions that can actually continue to make new brain cells into older adulthood. And one of those is the hippocampus, which I mentioned before, which is really important for working memory and for memory function in general. Neuroplasticity, which many of you may have heard of in the media, this is the ability of your brain to adapt when it's given certain experiences. And also perhaps things like brain-derived neurotrophic factor, which we know is a growth factor that can help to protect brain cells. We know that exercise can lead to increases in BDNF levels. So we don't quite know which of those is the most important, if they're all playing a role, how they're linked together, but we're certainly learning more about it, and there's some evidence for all of those. Diet was one we heard about before, so high intake of plant foods and fish. Olive oil is the primary source of fat, not so much meat and poultry, and perhaps most wonderful for people here in South Australia, a little bit of red wine. It's not going to hurt you. The key there is that you want a lot of antioxidants and polyunsaturated fats. You want to get your cholesterol down. We can see that in multiple studies now, including this one here, people who conform more to the Mediterranean diet actually have a lowered risk. But it's not just about Mediterranean diet, it's these guidelines in general. And cognitive reserve, which has already been beautifully explained tonight, which is things like education, occupation, and leisure activities. And the higher your cognitive reserve, think about it like a bank account. You're paying into the bank account so that you're better able to cope with pathology later. You can sort of pay the debt of pathology from your bank account, is how I like to think of it. And that gentleman there is my old boss at Columbia, that's Yakov Stern, and he's one of the big guys in cognitive reserve. So I feel like he would somehow know, there would be a telepathic signal if I didn't at least mention cognitive reserve to you tonight. So in summary, we are what we eat, and what we do, and what we learn. So stay active, stay engaged, and most importantly, go have another glass of wine.
Okay, so in the interest of being healthy and active, we're going to do a standing question and answer session tonight. So does anybody have any questions for these fabulous speakers? And I'll run up the stairs, eh?
I just had a question about Alzheimer's and the amyloid beta protein and wondering what the normal function of that protein is. Like, what's it normally used for when it's not a pathology that's leading to Alzheimer's?
Yeah, very important questions and very hard to answer. Amyloid beta protein is made from APP, amyloid precursor protein. amyloid precursor protein, APP, is one of the membrane protein. It's located in the surface of the neurons or some other cells. And some studies shows APP, amyloid precursor protein, has some roles in the axonal transport, so transporting something important in the cell, inside the cell. But not so much is known about the normal function of APP. Even almost nothing is known about amyloid beta. It's a very small piece of the protein of APP.
And I think it's an important thing to remember that all of these proteins we've mentioned do have normal, healthy functions, even when we're not completely sure what they are. So the tau that was mentioned before, for example, it wraps around what are called the microtubules in your axons, which help to send information from your brain cells down to the end of the cells. And we know that it helps to stabilize those microtubules. And alpha-synuclein plays a really key role in the connection between brain cells. It's a synaptic protein. So the proteins themselves aren't the problem. What happens in aging is that for some reason they start to get sticky and they start to aggregate. We don't totally know or understand why that is. So yeah, that's a lot of research now is trying to focus on that and on how those proteins may be sent from diseased cells to healthy cells and corrupt those cells.
Excellent. Do we have any other questions in the audience? In the middle, we have a question. Are we able to? There's a microphone coming.
Yeah, I hope this is not too specific, but I'm just wondering, I spent a lot of time working in the manufacturing industry and had probably quite a few issues with the younger generation from 20 to 35 that had a history of severe drug taking. And I just noticed they had a lot of personality difficulties, like they very, very easily get angry. They had limited sort of ability to participate in any sort of debate. And they were very highly opinionated and always right. And I just don't know whether there's enough time has elapsed to see whether that has any effect on the likelihood of developing dementia.
Yeah, so there are lots of generation gaps or generation change differences with many generations in all over the world. And something so similar is happening in Japan too. But such difference of characteristics of young people is not only from so it can caused by many factors, environment and maybe genetics and also food and exercise and so many things. So it's very difficult to predict so generation change have some role in the development of dementia. But one thing is dementia is increasing. So our lifestyle is not so good for the brain, I think.
Yeah, and I think I can comment a bit, so not from a dementia point of view, but from a Parkinson's point of view. So Gabrielle Todd from here in Adelaide at the University of South Australia, she's doing some really interesting work around sort of the ice epidemic, which of course has been so much in the Australian media. And she's showing that even with a very short exposure to ice, individuals are at a higher increased risk of Parkinson's disease. So given that there are so many similarities between the neurodegenerative conditions, I would expect that there'd be a similar trend for dementia, but that's harder to measure because it takes longer to see that, excuse me, that sort of cognitive change. But I think your point also illustrates a really important gap in the literature, which is that we need to be studying people before the onset of dementia or before they reach older age. And particularly, not even so much younger adults, but middle age. It's very much a group that has been understudied. And there's lots of reasons for that. One of the reasons is because, of course, in middle age, many people are raising their families, very actively engaged at work. So it's really difficult for them to have the time to go and participate in research studies, but definitely a group that needs to be studied more. And I'm working on a book right now called The Middle Age Manifesto, which is all about what people can do in middle age to try to help to stave off this dementia risk.
Thank you for the presentation. I wanted to ask, you mentioned that about 10% of people returned from mild cognitive disorders back to normal state. Do you have any ideas or research why that happens?
Yeah, mostly such recovers results from this lifestyle change, I believe, because of the nutrition. So thanks to nutrition or exercise, such kinds of improvement of lifestyle may result in the improvement of cognitive function as well. And actually, the data from UK or some other European countries shows that the incidence of dementia is decreasing in the wide population study. So that suggests current improvement of individual lifestyle may have some benefit for prevention of dementia.
Another thing that can contribute to that is cognitive testing can be very stressful for individuals as well. So sometimes if individuals are not feeling well or they're feeling very stressed out by the testing, and then the second go around they feel a bit more comfortable in the circumstances, that can also affect their performance. So it's really sort of difficult to tease that apart. But a lot of people, when they're told you do have a diagnosis of mild cognitive impairment, it's really sort of the motivation that they need to say, wow, I need to make some changes.
Do we have some other questions?
I'm just wondering, what are the chances of a medical breakthrough, or how effective are the drugs that are currently being trialled?
I don't know the data of the ongoing clinical trials, but still, newly developed antibody for amyloid beta has very strong effect on the prevention of amyloid beta deposition in brain. But the effect of such antibody in the patients with Alzheimer's disease, even though they have just a mild deficit of the cognition, it's not clear. It's not strong enough to prevent the progression of dementia in the patients. So they are focused on the people with normal cognition, so before they get the disease.
I'm going to try not to say nasty things, but amyloid beta hypothesis, it's tough to resist sometimes. So part of the problem is that the field has been completely dominated by amyloid beta. And this has, in many ways, drastically slowed testing of compounds targeting things like tau or other mechanisms like neuroinflammation. So a lot of those trials are still in their infancy and still well behind the amyloid beta because it has been so dominant in the field. But I think across many trials now, if we needed to cure Alzheimer's disease in mice and rats, I think we've done it successfully thousands of times. But it's not translating across to humans because amyloid beta doesn't seem to be the driving factor in the functional change. It seems to be what kickstarts the cascade.
So I think we might wrap up tonight because we've just hit 7:30. Thank you so much. What I will say as well, as a part of Australia's strategy to increase and boost dementia research, is our government a few years ago put aside $200 million for dementia research and to drastically increase the dementia research capacity. And we're one of the few countries in the world that also have a strategy moving forwards for an action plan against dementia. So your question about what's the likelihood of a breakthrough, I think the likelihood is good. There's a lot of research dollars going into dementia research at the moment, and I think it's lifestyle, like these two wonderful speakers have told us tonight, as well as the continuing of drug trials as well. But I'd like to take this opportunity to thank Professor Katsuno and Dr Collins-Praino, and I'd also like to invite you all to join us out in the foyer tonight for some nibbles. Yeah, thank you.